thank you for joining today's virtual educational program with Cancer Support Community Los Angeles. I am Edlyn Rodarte, and I am the Virtual Program Associate at UCLA. I welcome you to this week's webinar titled Cancer Genetics. We're not in Kansas anymore. Today we are joined by Mariana Niell-Swiller, Director of Cancer Genetic Counseling at UCLA, who will be sharing updates in the world of hereditary cancer and genetic testing. Mariana will be tackling and hopefully demystifying the world of direct-to-consumer testing. Is it all the rage or is it just hype? Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Without further ado, I'd like to welcome today's speaker. Mariana Niell-Swiller is a board-certified genetic counselor who has been specializing in cancer genetics and hereditary cancer risk assessment for the majority of her career. She has held a variety of clinical and leadership positions from small community hospitals settings to larger specialized centers such as the City of Hope Medical Center in Duarte, California. She now has the honor of providing hereditary cancer risk assessment to UCLA Health patients, as well as continuing to build cancer genetics programs in her leadership role. Welcome, Mariana. We're so excited to be hosting you today.
There are many parts of someone's life and experience that can contribute to their cancer risk. And you can see here that genetics is really only one very small piece of all of the things that can contribute to cancer risk. And so when I think about this, partly so that I can keep it straight, but also help explain why genetic evaluation can be helpful, I always like to break cancer down into three main categories. And you can see the biggest piece of this pie is sporadic cancer. And this is cancer that occurs just by chance because we all have a risk to develop cancer, no matter who we are. I think the statistic, and some of you probably know this more than I do, is close to 1/2 of us are going to develop cancer sometime in our lifetime. The sporadic category is the complete opposite of hereditary, of course. And in those families, we're able to notice a pattern of similar or related cancers from one generation to the next. And often we can, in addition to that, do genetic testing that identifies a hereditary change or mutation that can be passed down from one generation to the next that increases that family's risk to develop certain cancers. And you can see this is only a small piece of this pie. And then in the middle, the muddy ground between those two categories is familial cancer. And this is where we say, well, okay, we've done all the genetic testing we possibly know how to do in 2021. It's all normal, but we still have a family history that we can't quite explain away, right? We know we can't measure some of the things that we share with our family, such as environment and lifestyle, as easily as we can do a genetic test. So in these cases, individuals, even with normal genetic testing, may still have a slightly elevated risk for cancer that we can manage based on their family history. And so we touched on this a little bit just in this last slide, but only a small percentage of all cancer diagnoses fall in the hereditary category. And this 5 to 10% number is average. It really varies by subtype of cancer. So for example, ovarian cancer diagnoses, up to about 20% of them are thought to be hereditary. But it's still much less than half of all cancers, much less than half are known to be hereditary. And this is an important point when oftentimes patients will say, well, you know, I already have cancer. Why do I need genetic testing? Because I know I have the gene. Well, that's not necessarily true, right? Most of us who are diagnosed with cancer are not diagnosed because of some hereditary predisposition. Unfortunately, it's because we are human, and as we age, we all have a chance to develop cancer. Why is this important, right? Let's get to the crux of it. We want to make sure that we identify individuals who have a risk so that we can help. Sometimes patients will say, well, there's nothing I can do about it, right? If I do genetic testing, my genes are my genes are my genes, and I can't change them. And that is right? At least not yet. We're not able to change your DNA. However, we can do things like screening more vigorously or offer preventive options to help these individuals and their families. And so here's an example. You'll see throughout our conversation today that I focus mainly on colon and breast cancer. That's just for the sake of today's conversation. Many more cancer types can be hereditary. It's just that colon and cancer are pretty well known and pretty well studied, which is why I put them on our slides today. So here's an example of the risks associated with two well-known hereditary colon cancer conditions, Lynch syndrome and familial adenomatous polyposis, as compared to the general population risk. So anybody has about a 5% risk to develop colon cancer in the general population. However, if we identify someone as having inherited a predisposition to Lynch syndrome, we know that their risk is much higher than that and approaches up to about 80%. In these cases, we want to make sure that we offer screening colonoscopies starting at a much younger age than usual and doing it more frequently, right? So in the general population, we typically start colon cancer screening at around age 50 and we go every 10 years. In individuals with Lynch syndrome, we start at age 25 and go every 1 to 2 years. And then FAP is a condition that causes hundreds to thousands of polyps to develop in someone's colon. If these are not monitored starting at the right time, these individuals have a very high risk to develop colon cancer. But we know that colonoscopy is not just a screening tool, it's also a prevention tool. And so in these families, once an individual is identified with FAP, we can begin screening them and offering preventive options much earlier so that their risk of cancer is actually not going to be anywhere near 100%. The other thing I'll mention here too is that Lynch syndrome is not only associated with uterine or endometrial cancer, colon cancer, it's also associated with uterine and endometrial cancer. And so that is to say that each of the hereditary cancer genes are associated with their own subset of cancer risks. Most of the time, it's at minimum 2, if not more than that. And then here, as promised, is a focus on hereditary breast and ovarian cancer in these families with BRCA mutations, which are the two most common genes associated with hereditary breast and ovarian cancer. We can see a much higher risk of certain cancers here highlighted in teal as compared to average, which is pictured here in gray. So for female breast cancer, the risk in these families can be pretty elevated. Same thing with ovarian cancer, male breast cancer, prostate cancer, and a couple of things actually not pictured here. Pancreatic cancer and melanoma can be seen in these families as well. And so the point is, similarly to what we talked about in the colon slide, is that we can offer screening starting younger and going more frequently for breast cancer, or we can even offer preventive options like double mastectomy or removal of the ovaries. Why else does this matter? Family, right? We're all very concerned most of the time with children, siblings, parents, cousins. And we know that many of the hereditary cancer genes are dominant in nature. So if somebody is a carrier of them, there's a 50% chance to pass it on to each child. And because they're dominant, it doesn't matter if the carrier is male or female, or if the child is male or female. It can be passed down from any parent to any child. It also doesn't matter who looks like who, right? So some patients will say, well, I look just like my dad, which means I don't have it. We get 50% of our DNA from our mother. We get the other 50% from our fathers. So it's 50-50 down the road. It also cannot skip a generation. So for example, I could not have gotten DNA from my grandmother unless it went through my mother. And this is just a visualization of that. So this parent has 2 copies of gene W, let's call it. And we all have 2 copies of gene W. And one of those copies for this person has a mutation on it or a genetic error. And so this is why there's a 50% chance to pass it down to each child, because there's a 50-50 chance, or we only pass down half of our genetic information to our children. So genetic counselors are individuals who are trained in hard science and medical genetics, as well as counseling. And that is because we're here to help understand the hard science and apply that information to someone's family. Here are some facts about genetics and genetic testing that you may or may not know. They're actually now about 3 years old, so there are many more tests out there on the market, but in 2018, there were 75,000 genetic tests out there, and they were being added at a rate of 10 new tests per day. So you can imagine since 2018 how many more that is. And one of my favorite resources was published in 2008, so even older. But at that time, in that resource, there were 55 hereditary cancer conditions listed. In addition to all of that complexity, genetic testing can bring up a lot of ethical, legal, and emotional considerations. And really, genetic counselors are here to help the individual and family make sense of all of that. We can take a thorough family history, explore the risks that are there, identify appropriate genetic testing options, help the family with decision-making, right? Not everyone who comes to genetic counseling is interested in genetic testing, and we can help that person make the right decision for them. And we can then interpret the test result in the context of the family history if testing is done. We can provide education not only to patients, but other healthcare providers as well. And so when is it appropriate for someone to come for genetic counseling? Well, really, anytime anyone has any questions about their personal or family history of cancer, they're welcome to talk to their doctors about making an appointment with one of us. But in addition to that, some red flags to keep in mind as you're thinking about personal and family history of cancer. The first is that when we see multiple related cancers in the same individual or in different individuals on the same side of the family, especially if they're diagnosed young, under the age of 45 to 50, as they relate to colon or breast cancer. Or if an individual has a diagnosis of a rare cancer, or they have a close relative with a diagnosis of a rare cancer. These are all clear indications for consideration of genetic counseling to discuss genetic testing options. And now really to get to the meat of this, let's talk about genetic testing updates. So this is a really scrunched image of the timeline for genetics. And in reality, it's one of the newer subspecialties of medicine as compared to some other things. I think I had looked up neurosurgery, and apparently the Incas were doing it successfully as of the 1400s, right? So if we think about modern genetics, we really only started truly understanding what it's about in maybe, let's say, 1902 to 1953, when chromosomes were discovered, and then the actual structure of DNA was discovered in 1953. So I graduated grad school in 2006, which is somewhere over here. And we were just then really barely beginning to scratch the surface of genetic testing for hereditary cancer. In the mid-90s, we started offering genetic testing for breast and ovarian cancer, as well as for colon cancer. However, since then, we've come a long way. And let's talk a little bit about two of the main events that helped us be where we are today. So next generation sequencing is a method by which we can do genetic testing on many genes all at once. And this has tremendously impacted how we provide genetic testing services and care to our patients. This really became commercially available around 2005-ish. And then the next event that has really drastically changed the landscape is the Supreme Court overturning a gene patent that was held by one of the popular laboratories. Some of you may remember this whole thing in 2013, where basically up until then, a lab called Myriad was the only lab that was able to provide or perform genetic testing on BRCA1 and 2, which are the most common hereditary breast and ovarian cancer genes. But in 2013, the Supreme Court said, nuh-uh, DNA is natural, it's a product of nature, and it cannot be patented. So that allowed other laboratories to begin doing genetic testing on BRCA. And of course, because of that, the natural cycle of competition began, which then improved the product and drastically lowered the cost of genetic testing. I don't know what just happened. There we go. And just to give you an example or some idea of how it's come since then. So before 2013, we were basically only really able to do genetic testing on 1 or 2 genes at a time. So this BRCA1 and 2 testing might have been for someone who had breast cancer or ovarian cancer. Most of the time, that's all we were able to do, even though we knew and now definitely know that there are more genes associated with those cancer types. And down here is an example of maybe the 2 or 3 genes we would have tested for hereditary colon cancer. But we would have stopped there. We didn't often have the ability to go beyond that. Then after 2013, we started doing bigger panels, right? So maybe this is the panel I would have done for someone with breast cancer, and this is the panel I would have done with someone with colon cancer. So we began broadening our testing, but still keeping it somewhat focused on the disease type that we see in that individual or that family. Then, of course, there have been additions since 2000, let's say 16-ish. And as of 2020, this panel over here that you see, this represents 156 genes that we can do genetic testing for nowadays. Point being, if someone had genetic testing before 2013, and they have a relatively strong personal or family history of cancer, it may be very important for that individual or their family to consider updated genetic testing to encompass more of the genes that we might be worried about. And I show this slide to you, not because I need you to remember everything that's on there, but basically, if you took a snapshot of what was going on in my head when I look at someone's family history, this is what it would look like, right? So I wouldn't want to just test someone for a couple of these genes if I'm worried about all of these, right? And so to give you an example, of some of the data around this. A few studies looked at cohorts of women who had breast cancer and had multi-gene panel testing done, meaning broad genetic testing panels, not all the way up to 156, but definitely encompassing more than just the main cancer genes. One of the papers found that 15% of the mutations would have been missed if single gene or syndromic testing had been applied. It's a big deal. And then, according to some other data, up to about 5% of women who were tested had mutations in more than one gene. And so that's important because we want to identify all the potential risk that's there. The most common combination that was identified of the two genes was PALB2 and CHEK2. And again, I don't need you to remember that part. The moral of the story here is that had this individual not had a broad panel, and let's say only had CHEK2 testing, we only would have known about her breast and colon risk. We would never have known about her risks for pancreas and ovary. And vice versa, right? Had she only been tested for PALB2, we wouldn't have known about her increased colon cancer risk. And so while multi-gene panel testing has been very helpful, there are also some caveats to consider. And I think this is where genetic counselors can help individuals determine what level of information feels more comfortable. So the more focused panels, the panels that include the genes that are very well known, are much easier to interpret because we have a lot of information on them. And we typically have very clear guidelines. And those would fall into this first bucket right here. Then the broader we go, we might start including genes that maybe are pretty well known, but their risks associations are a little bit lower than this bucket up here, this top bucket. And potentially the recommendations that we have for that individual may still be based on a combination of what we see in their family as well as their genetic test results. And then this last bucket down here includes genes that are much more esoteric and maybe not as well defined. And so in these cases, we might say to someone, look, we identified a gene, a mutation in such and such gene. Currently, we don't have enough information to really tell you how high the risk is. And I say currently because this is always changing. We are learning so much about risks associated with certain genes, the more testing we do and the more individuals we identify, that this is a constantly moving target. And we do update individuals, and we always welcome individuals to come back to us or at least give us a call to discuss these certain updates. I did also want to go over this because it overlaps a little bit with what genetic counselors do. And before I talk specifically about what's on this slide, as I'm sure most of you, if not all of you, know, that a tumor is basically one cell that has grown out of control, right? That can become a mass, which then can become malignant. And part of that process is for that cell and that then group of cells to start accumulating damage to their DNA that makes that cell or the mass of cells able to continue growing and evade the body's natural response to usually getting rid of those types of processes. So based on a lot of studies, what you see on the right here is that tumors typically have their own genetic makeup. And we have been able to gather so much information based using this next generation sequencing tool to identify changes in tumor DNA that are specifically sensitive to certain medication. And so this is really the crux of precision medicine, which would not really be as possible had we not had next generation sequencing available. And then this overlaps with what we do in the hereditary world, because while most tumors acquire their mutations or their genetic errors over time, sometimes there's something identified on the tumor that is suspicious for something that possibly could have been inherited, right? And so this here shows the overlap. And when that happens, if the oncologist identifies that, or the surgeon does, or whoever did the testing, usually those individuals will then be referred for genetic counseling for that reason. So we have time for one case example, I think, which nicely takes into consideration all of the things we just talked about, or many of the things we just talked about. Those of you who have had genetic counseling and testing might be familiar with one of these. We call them pedigrees. They're basically just the family tree. And let me tell you a little bit about what these are. Circles represent individuals who are assigned female at birth, and squares represent individuals who are assigned male at birth. And in this case, this arrow represents the patient who came to see me. So this was the person who was referred. And she was referred because she was recently diagnosed with a very early onset breast cancer in her 30s. Excuse me. So you can see here on her dad's side of the family, this is her father. Her grandmother did have breast cancer, but she was older, in her 70s. And there's an aunt with breast cancer, but we don't know what kind. This stands for cancer not otherwise specified. Then on her mother's side, this looks much more concerning to me, right? Mom had colon cancer at 30. Aunt had colon cancer in her 30s. Grandma had colon cancer in her 30s. Great grandpa had colon cancer. And then this aunt had an unknown type of gynecologic cancer in her 30s. So back in 2013, I would have only been able to test this woman likely for BRCA. And I would have said to her, okay, we're testing you for BRCA, but I need you to talk to your mom about doing genetic testing for colon cancer. However, because I think I saw her in 2016 or 17, I was able to apply a much broader genetic testing panel. This panel happened to include 34 genes total. And we didn't identify anything problematic or concerning in any of the breast cancer genes. However, there was a mutation or a genetic error identified in this gene called EpCAM, which we know is associated with Lynch syndrome. So if we go back to the family tree, I can make an educated guess and say that this likely came from mom's side of the family. And if indeed that was proven to be true by testing mom, then this individual's maternal half-brother would have a 50% chance to also carry that genetic change, as would her full brother. Then the other thing I'll mention here too is that this individual, my patient, had 4 children, all of them still pretty young. And for the most part, because we know that hereditary cancer conditions tend to be adult onset, meaning they don't really pose risk in children most of the time, we don't do genetic testing in individuals before they're 18 years old. And I say 18 as the bare minimum, because for example, with Lynch syndrome, if let's say we identified her oldest son as also being a carrier, we wouldn't do anything differently for him until age 25. So sometimes it can be quite a burden to carry that information from age 18 to 25 without really being able to do much about it. However, it's always an option starting at age 18 if the individual is interested in pursuing genetic testing. Okay, so direct-to-consumer testing, out of the clinical world into the fun world. Um, there are a lot of hereditary of direct-to-consumer testing kits available out there. This is just a smattering that I found, and that I know a little bit about. Some of them actually do require some doctor involvement. Many of them do not. And I would say that this one right here is my favorite, the Vinome, which promises to help you find what type of wine you like. But I'm pretty sure I have different methods for doing that myself at home. I did actually look this company up last night, and it doesn't seem like they're doing genetic testing anymore. So I wonder what happened. Maybe it was the pandemic. I don't know, but they're not offering the test anymore. These kits are readily available at your local pharmacy. I just walked down to my CVS and took a photo of this one. And while I think these tests can offer some information to individuals, I think there's a lot to understand about them so that we don't misinterpret the result. So I've made two columns here, the direct-to-consumer column and then the clinical testing column, which is what we would do if someone came for a genetic consultation, clinical/medical testing. Particularly when we're talking about hereditary cancers, not all direct-to-consumer companies test the hereditary cancer genes at all. So they may not even be focused on the genes that you might have questions about. And then the way in which the genetic testing done is different. So in the direct-to-consumer world, it's kind of like reading the headlines instead of actually reading the article all the way through. So you might capture the general sense of what might be going on, but you don't know the details. There are also reports of very high false positive rates in the direct-to-consumer world. And those, when they are identified, those positives can actually be misinterpreted. This is very different in the clinical testing world because the laboratories are very controlled by rigorous guidelines, and they need to provide validation for all of the testing that they do. I took this directly from their website, so it's, they're not hiding it, right? So 23andMe clearly states that they only test for 3 specific genetic variants in the BRCA genes. And these 3 variants happen to be most common in the Ashkenazi Jewish population. So if you're not Ashkenazi Jewish and you have 23andMe testing, that testing doesn't actually really apply to you. And even if you are Ashkenazi Jewish and you do 23andMe testing and it's normal, that doesn't necessarily mean that there might not be something else there that this test didn't find. And you can see here at the bottom where I put the little mint colored box, there are over 1,000 variants in BRCA1 and 2 that could possibly be detected, and this lab only looks at 3 of them. So while I think these tests are really fun, I actually did Ancestry myself and found out that instead of being mostly Spanish, I was also French in background. I didn't know that, and neither did my parents. I do think they're really fun, but I don't use them ever for any medical management or clinical decision making. Even more than that, if a patient came in with a 23andMe report that had something identified in one of the genes, I would actually need to confirm that in a clinical laboratory to actually prove that it was there. And so with that, I say thank you to you all. This email down below is the email where you can reach myself and our coordinator. So if I'm not in the office, someone will be answering that email. If you have any questions whatsoever, please don't hesitate to reach out. Thank you so much.
Thank you so much, Mariana, for that information. I think it was, something that needs to be talked about more, especially with our population and going through cancer and genetic testing. So thank you so much. We are going to give some more time for people to go ahead. You can type your questions in the Q&A feature. But we do have one, and it said, please share about genetic testing was talked about / done in / through the Talmud. Very interesting.
Yes, very good question. Thank you for asking that. So it wasn't actually genetic testing. What it was a statement about which little boys could and could not be circumcised based on a family history of an uncle who bled too much on the mom's side. And that is hemophilia, right? So they recognized that pattern of bleeding before anyone ever knew about types of inheritance or hemophilia itself. They would say, if there is a maternal uncle who bleeds a lot or bled a lot during circumcision, you do not have to circumcise that little boy.
Oh, that's very interesting, actually.
Mm-hmm.
Okay. I do have a question. Is there ever been, is it possible to have your tests come back like uncertain? And if they are, what does that mean?
Good question. And yes, the answer is yes. Just like with any medical test we do, it can come back uncertain. And in the world of genetics, that basically means that the lab identified a genetic variation, but they don't have enough data to prove that that variation actually causes any trouble, right? Because we all carry genetic variations. That's in part what makes us different people. And for the most part, those variations don't cause disease. So in the case of an uncertain result on our genetic testing, we set it aside. We don't act on it because it's not proven to be dangerous. We wait until the laboratory can gather more information before we move forward.
Okay, makes sense. So we have another question here, and it says, for renal cell carcinoma recently seen on scans / ultrasounds and not much known about ancestors, can genetic testing help to determine if the RCC is benign or not, and how to handle treatment?
That's a really good question, and I would say that falls under the purview of the oncologist or potentially the surgeon or urologist you might be seeing, because that falls more in the tumor realm and not the hereditary realm. So the characteristics of the tumor itself are what's going to help make the determination about whether or not it's malignant and what kind of treatment would be necessary.
Okay. The next question asks if you can please repeat your email, or
Sure.
If you could just, can you type it into the chat?
I can.
Okay. And
I
then
will do that.
thank you. And while you're doing that, the question is, when is genetic testing paid for with a family history of colon cancer?
So I'm afraid that is a question that's very complicated, and it really depends on the insurance, not even beyond that. It depends on the plan. But most of the time, if you remember those red flags we talked about earlier, that's what insurances look for. So if it's a young diagnosis, or if there are more than 2 or 3 individuals on the same side of the family, oftentimes insurances would find it hard to say no.
I do have, I guess, a question myself. So let's say that you have already been identified as a having breast cancer. Does genetic testing allow for knowing if you have a higher chance of reoccurrence, or is that not too much?
Good question. So there are often 2 answers depending on what question we're asking. So the actual risk of recurrence is related to the diagnosis itself. So again, the characteristics of that tumor are going to tell the doctors what the likelihood is that that exact tumor is going to recur. However, we do know that individuals who have breast cancer and have a genetic finding have a higher chance of having a second breast cancer that is completely unrelated to the original. So it'd be a new primary cancer, either in the same or the opposite breast.
If someone was diagnosed with thyroid cancer, and they didn't get, their doctor didn't recommend any genetic testing, and then they ended up getting breast cancer, what genetic testing, let's say you got genetic testing when you were diagnosed with breast cancer, would it show the thyroid cancer, like that you were going to be exposed to that, or?
Only if there is actually something that predisposed someone to it, right? So it could be that, let's say someone had thyroid cancer out of the blue by chance, because that's most of the time what happens. And then later they get breast cancer, they have genetic testing and nothing is found. So that's one scenario, could very well be the case. Or there's something found that's related only to breast cancer and not thyroid cancer. And the third scenario is there's something that's found that actually connects the two cancers. So it's hard to predict. It's hard to know what the answer will be, but any of those possibilities would be there.
Yeah, okay. Is there certain testing to see if the two cancers were linked, or is that something that you would discuss with your doctor?
Well, that would be based on the genetic testing, right? So there are some hereditary cancer conditions that can increase the risk for both thyroid and breast cancers. But if the testing was negative, it would be hard to say what could have caused those both cancers in that same individual.
Okay. So let's see. So if you're having any issues seeing the email that we typed into the chat, if you guys would like, you can go ahead and send a message to info@cancersupportla.org, and we can go ahead and send Mariana's email through there as well. But I want to thank you again so much for this presentation. Again, it was great information. It's going to be a great asset. Everyone, again, this is being recorded and is being streamed on Facebook Live. So if you would like, this will be up on our virtual library within the next few weeks. But thank you so much, Mariana. Is there anything else that you would like to say?
No, thank you. I really appreciate your interest in this topic. And for anyone who has additional questions, please don't hesitate to reach out. And usually, if you are concerned and you really have additional questions about your personal or family history, talking with your doctors is your first next good step, and then they can send you in the right direction.
Thank you. Actually, if it's okay, we actually got a question that just came in right now.
Sure.
Okay. It asks, are there genes that show predisposition to bladder or kidney cancers?
The answer is yes and no. So bladder cancer is not typically associated with hereditary conditions, depending on the subtype. And there are genes associated with hereditary kidney cancers. But again, if it's one individual in the family diagnosed at a routine age, like above 50, and there's nobody else in the family, I'd be much less concerned. But if there is a pattern of cancer, of kidney cancer, especially from one generation to the next, then it might be worth asking the question.
Well, again, thank you so much for all your information, for answering all the questions that we had today. We appreciate it. Thank you, everybody, for joining today. And we'll see you next time.
Absolutely. Have a great day and a nice weekend, everyone. Bye.